be a standalone medication to treat this with the idea that this is going to be resolved solely in that manner. And kind of looking at then from the side of being a clinician, what does that then mean in terms of what's in my scope to do and what's not, okay? Looking at stuck trauma loops. So here's where I would say there's a lot more, but your top 5 correlates where you see where chronic pain and stuck trauma go hand in hand. A few things is one is they tend to share the same pathways. So chronic pain and trauma both involve dysregulation in the amygdala, the hippocampus, your prefrontal cortex, which all reinforces just maladaptive stress responses, right? So all the presentations before me did a glorious job of talking about the brain chemistry and the neuromapping and what gets affected with chronic pain. So we know that to be true, that those loops are affected in there, and we see that with what we would consider complex trauma presentations that aren't involving chronic pain. So that's just kind of an additional component that gets added into there. Second one is you're going to see a lot of nervous system hypoarousal. So prolonged pain is going to agitate and activate the HPA axis, which is our sympathetic nervous system, connects to, and essentially it just perpetuates the fight-flight response. When fight and flight are exhausted and there's no way out of that, then you're going to see the freeze response come in. The problem with often where we start out working with a lot of our patients is when we start working with freeze response and we hop right into Western techniques like EMDR, prolonged exposure, narrative therapy, our intake forms ask them to name all their traumas when they occurred. And that part is we engage in trauma flooding when someone is already flooded, right? Yeah. And so this is not particular to chronic pain. This is my little soapbox for working with trauma in general. Yeah. We need to stop doing that. Yeah. That is absolutely unnecessary. We're adding far more suffering to the field than what is required when the person is clearly already suffering in front of us. So then the question is, well, how do I get all my information that I need at the time? Is what is the information that is most pertinent to working right here, right now? Do we have concerns about being on the planet? Should I be concerned that I might not see you next week, right? Tell me what is going on in your world right now. If there was one point of focus that would make a huge wealth of difference to you and you felt like this would be the most effective use of your time and energy to come hang out with me, what would we be tackling? Start there. The stuff that happened to me when I was 5, 10, 12 can be discussed later. It's kind of like opening Pandora's box when you have no intention of helping them put the stuff back in the box, okay? So this is kind of the idea of really understanding the nervous system hypoarousal is happening for the majority of our clients. When you add chronic pain to it, it's an even more fatigued system, right? So these are things that we want to be aware of, and I think this is really what trauma-informed care is. It's not this idea of I have pamphlets about trauma in my waiting room. It's I really understand how trauma is processed, and I understand clinically what my role is in not agitating the system before there's containment and actually resolution in parts, right? We want people to go there when they have bandwidth to go there. When people are presenting to us, they don't have bandwidth. Trauma loops is kind of the next one, and this is what we would consider intrusive memories, ruminative thought patterns, flashbacks, pain signals that create this feedback cycle, where essentially the more that it flashes forward, the more that it feels unresolved, the more exasperated my actual physical feeling or sensations of pain increase, while my actual sense of terror and fear is also increasing at the same time, right? So this is kind of a big part where we know with a lot of complex PTSD presentations, sleep disruption is one of the primary considerations of treatment first, as Michelle was talking about how important that is to us. So much of that has to do because of the hyperarousal components that are happening and the trauma loops that are happening with the night terrors, with the flashbacks, and we actually begin to have anxiety over having anxiety, right? So with anyone who's treated panic attacks, you know it's not actually the panic that's the worst part, it's the fear that they have that this will happen again, and they have no control, and it comes on with no warning, right? And so working through that perception of fear that we actually do have a lot of control, that starts with our nervous system being regulated. That starts with you being able to read and have interoception of your own nervous system, and then have some correlation to how your nervous system is regulating around other people's nervous systems. That's how we don't need to be afraid of this anymore, right? So I think these are the parts that we want to start to look at. The other one is neuroplasticity and sensitization. Repeated activation of your brain centers creates a stuck loop of this will always happen, I will never get out of this. I invite you all to think of a day, which I'm sure none of us have had, where you have been horribly hungover. And the next morning you were like, I swear to God, I promise I will never drink again if you just like help me out here, right? As we're hugging toilet bowls. So when that has occurred, well back in the day, right? This idea of the loop is like, this will never end. It is forever, right? If you've talked to anyone who has given birth, anyone who has broken a bone, it is this like all-consuming, I can think of nothing else situation, right? And then, you know, it's always like one of those parts of like, okay, so let's talk about what your homework is for the week and da-da-da. And they're just in this loop, right, of what's happening. The last kind of piece that I'll speak to on this, and again, there's so much more to add here, but these were kind of the top 5 that I particularly see most often, is that there's a need of integrated approaches, that this is not you do this one technique, this one exercise, this one journal entry, this one app, and this goes away. There's not a single medication. That does not exist. There has been no species of humans since existence where one form of treatment or modality alone has ever proven to take away human suffering. It has happened in tribe, it has happened in connection, it has happened in belief systems, it has happened ideologically, it has happened in societies. So it's always, every presentation up here has talked about, here's like 15 different things to be considered, right? And how we navigate this. So I think this idea of integrative approaches is not just cute. It's not just like a good idea. It's not just for people that can afford it. While access to that gets narrowed down, resources get narrowed down based on communities and socioeconomic status and us knowing about it, it is really a paradigm to us actually doing recovery work versus management work, right? So my little soapbox on PTSD particularly. PTSD is one of those diagnoses that essentially, very much like some of our other diagnoses that we've been looking at, has primarily been seen as a diagnosis that you just manage for your whole life. In the DSM-5 today, PTSD is not considered a resolvable condition. Once diagnosed, it follows you, and it has degrees of severity of are you exhibiting, is it chronic, is it not chronic, which most people diagnosed with PTSD have had this for years, so at what point we're determining chronicity? Is it the amount of traumas? Is it the intensity of which your recovery has abscess, right? The whole idea of it is pretty antiquated, right? But essentially, we need languaging to say, this is not just generalized anxiety, this is no longer just panic attacks, this is not just situational, this is a state of operating in which someone is in hyperarousal all the time. So enter PTSD. Brief synopsis in history, PTSD really wasn't on the mainframe of psychiatric or medical communities to look at. I think back in the earliest literature that we find about correlates of this, or this even being studied historically, is from essentially accounts of folks coming back from war after World War I and shell shock. What shell shock looked like to folks was catatonic states, and pretty much folks got coined as just being psychotic. A part of them broke and they couldn't come back, and that's what that was. The governing nations at the time, and the ones that were running hot, putting a lot of money into armies and utilities and stuff like that, Great Britain, the US, very other big nations, were like, this is a really bad PR look to elicit guys to go off of farms and to go into that. So what we need to do is coin this as, this is not about the person's nervous system, or this is not what humans do when they go to war. This is about personal inadequacy and failure to handle stress, right? And so what we did was we built things to better help people be desensitized to their stress responses. This is the whole point of boot camp. This is why we do trainings. This is why we do shooter trainings and fire drills, is to train your nervous system to not freak out and have a stress response. Anyone that has worked on a hospital floor, you have delayed stress responses. You get through your whole day, and then you implode in your car, in your bathtub, your kid's PTA meeting later, right? Like, that's how that works. So this whole kind of place of desensitization and how to look at this culturally has come from. PTSD really got on the scene by, a lot of the forefathers before us, or foremothers before us, but the big hub was in the 1970s, was actually a lobbyist group that came together of Vietnam veterans and women's sexual assault survivors. And they basically lobbied together their efforts and said, this needs to be looked at. This is not just a schizophrenic diagnosis. There's a lot more involved here. This is not just like me being hysterical at the time. And really, that's kind of what moved the needle forward into maybe we need to consider this its own diagnosis and its own parameters and where that's at. So very brief and short history, partially scientific about PTSD and how it kind of came to be, but really understanding that this is really a diagnosis of the last 50 years as even having a more clinical landscape of what it is, right? It's a fetus in comparison to how many other diagnoses we have out there. Because of that, there is nothing but rampant information popping up. And because we live in the West and we love research and we love data and we love all these things that can be proved, where have we spent the majority of our time focusing? The brain. What do we know about the brain? About 5 to maybe 20% of its capacity with all the millions that have been spent. What are the aspects that have not been studied? Women. More studies have been done on rats, male rats, than females actually participating in these, right? And so I think this part is, it's interesting that females drove this diagnosis to the forefront, but we are some of the most understudied representation, and then don't even get me started on BIPOC women being represented in this, right?
Yeah.
So I think like there's this whole other component here of we just don't know. But what do we know? We know that we have nervous systems. So no matter what ethnicity, no matter where you are on the planet, if you are a human, you have a nervous system. Nervous systems have a level of predictability of how they function, right? And so I think part of my outlook and how I look at this and how I like to do integrative work is really looking at this from a human mammalian ancestral lineage, like human evolution psych. If you can dial it down to stress response, there has always been traumas since humans have been on the planet. There's not a generation of humans that have not incurred trauma. Some people might dare to say traumas are a rite of passage of just being a human. How is it that of 100 humans experiencing the same thing, 5 to 20% are going to develop complex PTSD symptoms, right? And it's like that resiliency factor is what, military units, elite performance operations are all questing to kind of understand what makes you actually resilient to it. It's not actually not incurring the trauma itself.
We all experience trauma, but not everyone gets PTSD.
Right,
Yeah.
so what we're finding that is the actual correlate of resilience is, what do I make it mean about myself or my abilities once this event has occurred, right? Which is why often as a trauma therapist, I don't see a lot of single incident traumas, because single incident traumas are usually taken as a one-off, right? So God forbid I get into a car accident, that type of stuff, I'm gonna have a PTSD reaction post that. I'm not gonna wanna drive, I'm gonna be hyper vigilant, I might have a high startle response, I might have some nightmares, I might have some crying spells, I might have a whole like somatic experiencing of feeling like I'm going through, hot flashes and then icy chills. I can have all of that, but essentially over a period of time, that will desensitize. And if I haven't had a chronic history of car accidents or fatal injuries or people in my life that have had that, it's like, Lisa, you've been driving for how many decades? This is a one-off. This is ridiculous. San Diego has terrible public transport. You have to drive. You live in North County. Suck it up, buttercup, right? And like, you get behind the wheel and you work through that. That's a single incident trauma when there's a resolution to the traumatic energy. It can be moved, it can be met, and my abilities, there's interestingly enough, post-surviving a trauma, when there is recovery, people have a greater sense of competence about their abilities than before the trauma occurred, right? So if you've ever been through significant hardship and you're like, holy shit, I didn't know I had that in me. Oh, yeah, look, right? Like, I can do anything, right? Like, in that vein. So this idea of resiliency markers is not so much in the events that have occurred or not occurred, or even all the resources that we have. It's more about what is my perception about myself or my abilities now that this has occurred. And this is why often we are more seeing complexities or multiple incident traumas or things of this nature. Not everyone who goes to combat, frontline exposure, even folks that are in sniper school, are going to develop PTSD when they come home, right? It's really much more about what is my sense of self and what is my sense of ability and how do I make sense of being a human in this planet right now that gives me resiliency factors of how I'm going to be able to acclimate back into everyday life. Okay, so these are, I think, some of the things that we want to really look at and understand when we're working with trauma. It is very salacious and it is very hard not to get caught up on the trauma narrative. Oh my God, this happened. Oh my God, this happened, right? And we know from ACE studies and whatnot, oftentimes having a higher ACE score means there's a predictability that we will have more traumatic events occur to us and more narratives to pick up. Trauma therapists hopping right into trauma narratives out of the gate is how we flood patients.
With pain, experiencing the pain is a trauma in itself, and when it keeps on ongoing, how does that fit in with what you're talking about? Like how it doesn't get processed?
Yes.
So that's where ketamine kind of comes in.
So this is part where ketamine comes in, but this is also we're looking at, because this is, for whatever reason, this is what's happening in this lifetime, right?
Yeah.
Okay, like I didn't choose endo chose me, this sucks, I don't like it, this is the stuff I can't do, it took me forever to even figure out this is what it was, I'm so pissed off that this is where I'm at, right? As an integrative therapist, my role initially is not to necessarily go down, well, let's go through your entire history and how many things you tried and look how resilient you are. You keep advocating for yourself, right? And like maybe we just get some stretching in. Let's do some pelvic floor stretching. And I'm not a pelvic floor therapist, but I've heard this works, right? Like let's do some of this stuff, right? Versus, wow, this is a really long journey you've been on. Can we just take a breath for a second? Can you and I just imagine like we're sitting on this edge of discomfort and we're just going to sit down together for a second. You have really been through some stuff. Just breathe. You and I will have plenty of time to discuss all the really important headlines that you need to tell me about. Right now, I just want to acknowledge, like, it is amazing you are in this room with me right now. Right? Simple human-to-human connection, validation. I see you. I don't even fully understand it. Maybe this will be helpful, maybe this won't. But for a moment, can we just slow it down? Right? And this is kind of where nervous system regulation most comes into. Nervous system regulation cannot occur from your brain. It cannot occur while you are sprinting down the block. It cannot occur while you're multitasking on your phone, ordering groceries, thinking about where you're going for dinner, and trying to see a client via telehealth, right? Like none of that stuff can happen at the same time. Nervous system regulation requires stillness. It requires the ability to just, can you be here right now and not add any more or any less to this moment? Right. So one of the parts that, and I will just give just a very quick, honest, like 2 cents about ketamine. I've been working with ketamine assisted therapy now for about 8 years. When I first started here about 10 years ago, and it was like I just had patients that were just very frustrated. They had tried a lot of different things and it just wasn't working, and they were just like, that's it, I'm gonna go do ayahuasca. I'm going to, I am going down south and we are doing this. And I'm like, you're doing what? And like, we had these conversations and they come back and they're like, it's amazing, I'm cured. And you're like, fabulous, cool, that sounds terrifying. And then 6 months later, here they come again and it's like worse than where it was at before. And it was like, I thought I had it, I don't have it. This other event happened and it broadsided me and it took me out. And what we started to notice from the first generation of folks utilizing this were kind of what I call in the second and third iterations of folks. But originally it became like, here's this thing that takes your immediate thoughts away. Here's this thing that changes your perception about this right here. So we sent all of our special operators veterans repeatedly down to Mexico, down to these places to go do these journeys with no prep, no integration, come back, and then go right back into the lives that they had, right? But my lifestyle, all the energy that I had up here, how I was living, how I was thinking, of course it all came back over time. And then what we noticed is it caused increased rates of suicidality because it was like, I did this ultimate thing. I talked to God and I like thought it was gone. And then it came back. I must forever be broken. What is the point, right? So this next round, and this is kind of how I got involved with ketamine, was like, okay, what do we have legally here to use, right? So while MDMA and psilocybin and all those things are out there, this is what we have on the table now, as close to a psychedelic derivative or a plant medicine derivative that's not plant medicine. We also have cannabis, that's another area that we can utilize. But how do we complement this in a way that makes sense in navigating this? When I first heard about ketamine therapy, I had absolutely no desire to participate in it. I was like, oh, this is like snake oil, like we cure PTSD with ketamine. I was like, okay. And then I went to a clinic and I saw a client of mine who was really struggling with suicidality and was kind of at that border between needing inpatient, but always he knew how to work the system and he had enough passive suicidality where he'd be like, well, it's not imminent, right? So you're always in that gray area, and it's the guy that keeps you up at night and you're like, okay, hope that's okay, right? And he's like in the back of your mind. Went and did a session of ketamine, let me kind of be in the room as a guy because he was nervous about it. And I've never seen a single session of any substance pivot the perception of maybe I don't need to consider this today. It didn't take suicidality off the table, but it took eminence and it created a pivot. Maybe this isn't what I need to be doing right now. I have a personal belief that I think in the next 10 years, hospitals will probably start using ketamine therapy in ERs as a frontline response for acuity of 5150s being brought into hospitals. I personally think the ER is probably one of the worst places to do ketamine if you were to take a place to do ketamine. So this is not something that I think is going to be great, but in terms of they're likely not going to spend millions of dollars building more hospitals and training more people to work with suicidality, right? But suicidality is a component that we have in the medical field, and how do we more effectively treat it? So what we know about ketamine-assisted therapy and what it has kind of been glommed onto as use for is for considerations that highly involve depression presentations, ruminative presentations, OCD, anxiety presentations. Now it is extended in force. It originally came on the scene as this idea of working with treatment-resistant depression, and that's what it was coined for. There is a synthesized version called S-ketamine, which is by Spravato, which is a nasal spray put in place by Johnson & Johnson, and that is essentially utilized and has a full REMS protocol for treatment-resistant depression considerations, primarily and solely. And then it has a full protocol on which to use. That is the only version of ketamine, and again, it's a derivative of, but it's the only version that is what's considered insurance covered. Right? So I think this really understanding that most of these services are traditionally a cash pay model. Ketamine can be administered orally, which is lozenge tablets, not to be confused with microdosing. No one should there's a potential for dependency on the ketamine, right? Which is going to be true for any medication that we use. It is a Schedule C substance, so there is concern around abuse potential. Oftentimes it's abuse potential because we've relied on it for all of our distress tolerance skills instead of building skills, and now it causes more distress to not have it.
So the goal is really to get the person off of the
the goal is to fire me. The goal is to you don't need to hang out with me anymore. You've got this, and now we're moving on to other things that are therapeutic. That's maybe not therapy. Like you're in nature more, you're biking, you're whatever. You're doing you. You're living.
Even if it were done nasally.
Nasally takes a longer term, and actually Spravato is it's a whole other paradigm. It's a much different dosage plan. REMS protocol dictates how it's done, so it's twice a week for 4 weeks, and then moves into once a week for 4 weeks, and then reevaluated. But Spravato is considered a PTSD or treatment-resistant depression management medication. To replace other medications folks would be on that wasn't effective for them. So Spravato is meant to be used longer term for that reason. Yeah.
So your clinic uses the IV method
Predominantly.
And after your assessment, you may or may not continue therapy, the psychotherapy with them. You may, but maybe you are looking for people outside of your clinic to do that.
Yeah, we have both. So I'm a clinician, and then I have a small team of clinicians that work in the clinic to offer this service. We have a lot of clients that are referred to us from their clinicians. And so our goal is to just ensure that they have access to someone to do this work with, and are they comfortable with that person, and does that person feel confident to do that? So
and you recommend that they have psychotherapy with the ketamine?
I do. There's a couple of different ways. There's traditional CAP, which is having a guide in the room doing therapy with you. It is pretty cost prohibited, and while it is considered the gold standard of how to do it, I'm not really sure it is any more efficacious than having really good prep and integration sessions pre and post your journey, where someone's more conscious. Coming out of a ketamine session is like jello setting, and you're just like, like wobbly. And so the the level of interpersonal connection. I don't personally want my clients going back into that cerebral rumination phase post-session, so I don't want to have a session with them until they've had 24 hours after a ketamine session to integrate.
Okay, so you recommend that they make an appointment with whoever?
Yeah, and I err on the side of like slow and trial. So my preference is that you would have 1 to 3 prep sessions, so we really understand your nervous system, what's working, what doesn't work for you. Let's have you start consciously moving your own energy in your body and challenging your own thought perceptions without relying on this medication to assist. And that way, and helping the funnel come down, right? So if my whole first session is an assessment, basically like understanding the ball game and working through the emotional dysregulation that's in the room, the next part then is essentially getting really clear, okay, what are we tackling with this first ketamine session? Like, what are we going after in this series? So if I've had complex depression for so long, I'm likely not gonna walk away from 6 sessions without depression. But maybe what I can do is walk away with this idea of like, I don't need to keep toying with being on the planet or off the planet anymore. I have 1 foot on, 1 foot off, and it's causing this like, back and forthness. Maybe I need to decide to put 2 feet here, right? Like that would be a significant gain as a clinician if my client was like, okay, we're gonna take suicidality off the table and that's the point of focus for the next 6 sessions, right? An idea. So it's kind of like triaging it like that.
I actually brought in a somatic therapist colleague, and she did some body work while I was there, which was amazing.
Yeah.
Yeah.
My favorite way, if I was to like run the world, and how I would administer this if this was used, is this to be mirrored in a journey setting that you would do other plant medicines in. So there would be a somatic grounding component and mindfulness component to get the body into a space of rest, a sound bath, then you would have a ketamine journey, then you come out with a sound bath and do that. So I actually try to do those quarterly at Daydream. I have a provider one coming up on the 14th of November to just help display and in that component, the set and setting really does affect how the medication happens. So in those journeys, people are more having kind of spiritual interconnected experiences and a whole person experience versus a symptomology focused movement. It's kind of different, which is also why doing ketamine in a clinic setting already presents a whole host of issues, right? People are already in a detached space from physical nature and things that we inherently find grounding. So then how the set and setting is set up, who's around, how people attend to this, does the orientation of staff. When I first started doing ketamine assisted therapy, there would just be nurses talking to the patients the whole time. And then there would be folks talking on their cell phones to their colleagues right outside the door at the VA. And there would just be, and it was just all that was coming into people's journeys, right? So it's still very new in terms of intervention and considered novel. So there's still a lot to glean and learn in it, but I don't think it's going anywhere. I think it's here. So it's kind of like telehealth for therapists. I don't think we're going back to full in-person anymore. Yeah.
But will we get paid?
Yeah, right. Yeah, that's the other issue. All right, you guys, thank you so much.
Well, that was a lot, everybody. You got a full spectrum. You got down in the dirty pelvic health. We got the ketamine, we got the cannabis. So I hope you walk away with some ideas and tools for your patients, because we're out here, it's just finding us. That was great.
Thank you.
No, it was great.
Thanks everyone for coming. I just wanted to take a
I
moment
have
to
to send-
introduce
I have-
myself. I'm Michelle Purcell. I'm going to be the SVP